Good morning, everyone. I'd like to start by thanking Julio and the conference organizers or the workshop organizers for inviting me to give this presentation. It really is a great privilege and honor to be able to present these results today. So I have no conflicts of interest to declare. By way of a brief introduction, so fantastically the target of 15 million on treatment by 2015 has been achieved. Really wonderful. But in order to meet the 1990 target, we need to dramatically increase the number that are under treatment to meet that goal. So I guess the good news is that we've learned to provide ART to essentially the volunteers and able people who can make it to clinic. The bad news is we've not learned how to get people who are not motivated by their sickness, have barriers to accessing care, who don't want to come or don't even know their HIV status. And that's what we kind of need to move towards if we are to meet the target. So what I want to do today is to present a series of studies that are going on at the Africa Centre and data from those studies to inform how we can move to meeting this target. So this is the outline of my talk. I want to start by giving a very brief overview of the Africa Centre, talk about the treatment cascade in the ANRS treatment as prevention trial, talk about some dynamic treatment cascade work we've done at the Africa Centre, speak about inequality and access to ART, especially with regards to gender, and then end with some population viral load work. Okay, so as an overview of the Africa Centre and to kind of orientate you to the epidemic context, the grey area there shows our HIV surveillance in the Africa Centre. So we are based in northern KwaZulu-Natal. There are 90,000 people living in that grey area there, and they are visited every year to test for HIV. So we go actively into the community, knocking on doors, asking people to test for HIV, and that's been ongoing since 2004. So now, in terms of an incidence cohort, we have about 60,000 person years of observation and 2,600 seroconversions observed to date. In the neighbouring areas, the treatment as prevention trial, the ANRS 12249 trial, Francois Dabi presented on this earlier, so I'm not going to go into detail. Just to reinforce the numbers there, to say that's 22,000 adults in that trial, and it's powered to detect a 34% reduction in cumulative incidence by mid-2016. So the Africa Centre, here are some typical scenes. So this is predominantly a rural population, although there are pockets of urban and peri-urban populations as well, and I'll be speaking about that. So the Africa Centre has an incredibly high prevalence and incidence. So prevalence is about 29% population-based, and incidence peaks at about 7.5 new infections per 100 person years in young females aged 24, and slightly later males aged 29 at about 5 new infections per 100 person years. So young females particularly have sort of outrageously high levels of new infection in this population. And although incidence is starting to come down, that group remains a sort of key area of concern. Another thing just to mention is there's this incredible heterogeneity in HIV incidence or in lots of HIV outcomes, and you can see those ellipses there represent formal clusters of infections, and these are our peri-urban communities located along the national road, highly mobile communities. So hopefully that's given you a bit of an overview of the epidemic context in which we're working. And now I want to speak about the treatment cascade in the treatment as prevention trial. So this is work presented by Colin Zawiji et al. And also Joseph Lamarage at previous conferences. So if we look at our total HIV positive population there, of those infected, 86% are diagnosed, so close to the 90 there. 70% are ever in care, 54% retained in care, 45% on ART, and then overall 38.1% virally suppressed. And the dark green blocks there represent the additional benefit gained through the trial, so through the treatment as prevention trial, over and above what was existing at baseline. And I don't have time to present that in detail, but I'd refer you to these two posters that we presented over the course of the conference. Now, in terms of understanding a sort of continuous time treatment cascade, so one of the beautiful things about the data at the Africa Centre is we can observe people before they know they're infected. So we test them, they may not know they're infected, They may not have accessed care, but we still have information on them. So we can build a really true treatment cascade. We can look at that dynamically over time. So this is work done by Noah Harbour and colleagues, just been submitted for publication. And this is an example that looks at the continuous treatment cascade between 2006 and 2011. And the main message here, if you look at 2006, there, knowledge of status was about 30%. By 2011, that increased to just under 75%. So I guess the good news is that there's been this dramatic increase in people who know their status. We're moving towards the targets, but there's still a long way to go. And then if you compare this way of doing things, a kind of continuous synthetic cohort approach versus a standard cross-sectional treatment cascade, what you see is that you continually underestimate various bits of the cascade, or sort of you overestimate it if you do a typical cross-sectional way, but you get a more realistic perspective by looking at it in a dynamic cohort approach. So one of the big issues is this inequality in access to ART, and if we are to meet the 1990 targets, then we need to close some of those gaps. And one of those gaps is access to care, physical access to care. So we need to be going into the communities to reach some of these people who are not accessing care. And this is one example of the impact of physical access to clinic on ART uptake. So this map here that shows the adjusted odds of being on ART given need as a function of distance to nearest clinic. So at roughly 5 kilometers from a clinic, an individual is less than half of odds of being on ART relative to someone living right next door to the clinic. So the populations there shown as shaded lines, that's 31% of the study area or 20% of the population, have half the odds of being on ART. So even in this area where the care is fully decentralized, where clinics are not that far away, still at just over 4 kilometers from the nearest clinic, odds are half of being on ART. And again, this really speaks to mobile testing and some of the wonderful work that we heard presented earlier from the search trial in Kenya and Uganda could really be used here. Going further with the inequality, just looking at the overall and cause-deleted life expectancy by sex. So these two graphs, you've got females on the left, males on the right. The red bars there represent cause-deleted life expectancy. So that is life expectancy in the absence of HIV. And for women, you can see it stays relatively constant at 75 years of age. Men at about 65 years of age, relatively constant over time between 2001 and 2011. However, if you look at the blue bars or the grey bars just below that, you can see how that line there, that vertical line, represents the time at which ART was introduced. So that's 2004. And you can see almost immediately there's a massive kick up in female life expectancy, HIV related mortality. So that a female in 2004 would have been, the average life expectancy would have been 50 years of age. By 2011, that had increased to nearly 65. So you have this incredible increase in life expectancy across the female population over that period. For men, however, the story is not so good. There you can see there's a slight increase, 5 or so years, but not nearly benefiting to the same extent. And this kind of differential access to ART is something that needs to be really met or really closed if we are to meet those targets. So this graph shows then the increase in female life expectancy over time, and you can see that that gap is growing, so about 9 years in 2011. Now just quickly, in the time that I have remaining, speak about some population viral load work. I mentioned earlier that a real cause for concern is the incredibly high incidence in young females. And here you can see one of the reasons for that. So this is population viral loads. This is across the population, irrespective of individuals knowing their status, irrespective of whether they're in care or not. And you can see how much higher it is in males on the right compared to females on the left. And so one of the things we really need to do if we're to look at the fourth 90, Myron Cohen's fourth 90, which is 90% of transmissions prevented, then we really need to get that male viral load down. And that just reflects the difference in access to care. And that's one of the real challenges going forward. So now if we look at that population viral load geographically, what you can see, so this is geometric mean population viral load across the population. That line there showing KwaZulu-Natal Township is the area of highest incidence. So what you can see is the areas of highest incidence corresponds to the areas of lowest geometric mean population viral load. So in a sense, the geometric mean viral load is good for showing you where the program is being effective in suppressing viral loads in positives. However, it's not so good for an HIV, for identifying areas which have high HIV transmission potential. And that's because of the massive differences in HIV prevalence. So if you think of two communities, one community has few numbers of HIV positive individuals, but they all have quite high viral loads. Relative to another community where the prevalence is very high, there are lots of infected individuals, but those individuals have slightly viral loads. One might expect more transmission potential from the latter community. And so this is the population prevalence of detectable virus. So this is predicated on the notion that if I reach into a community, grab someone out, what is the probability that person is infected? So this looks at, the probability that they have unsuppressed virus. So this looks at positives, negatives, everyone. And this corresponds really closely with what we see in incidence. And we're able to predict incidence very accurately going forward on the basis of this sort of metric. So just in conclusion, the lessons learned. So substantial progress has been achieved towards the target so far. But there's more population-based implementation research needed. So if we're to learn what happens outside the community, outside the facility to get people into the facility, we need to be in the community. So there's a need for more home-based testing, mobile testing, other sort of innovative approaches, and including the use of incentives. And there's many studies, including we're in the planning stages of one as well. So reaching the 1990 target will require targeting of difficult population subgroups and geographies as well. I'd just like to end by acknowledging all of my colleagues and the funders for this work. Thank you.